As stated, my name is Dr. Gugel-Bryant. I am an ambulatory care clinical pharmacist, and I really enjoy endocrinology, and I also very much enjoy geriatrics. I probably stem from having to care for my grandma for 14 plus years, and so I very much enjoy geriatrics as well. Now, let's get on with the presentation. Let's see. I'm trying to advance the slides, sorry. Cool. Just as a quick disclosure, number one, I have nothing financial of a disclosure. These slides were given to me from the American Geriatrics Society's teaching module for the Geriatric Fellowship. So I am giving the credit to a lot of the initial creators. I did adapt the slides for us. I do reference the American Diabetes Association and their guidelines. So just that's another point of order there. Next slide. My objectives are as followed. I'm hoping we can leave here understanding how hormone levels do change with aging for the most part, as well as describe some of the signs and symptoms that might imply certain endocrinology or metabolic disorders occur. There are some elements of assessment that are needed to understand how to have a complete care for diabetes in the elderly population, as well as to describe how to develop an individualized management plan focused on the patient's goals, values, and preferences. Next slide. Now, I do want to point out that I had a bit of a misunderstanding of something, and I'm going to be reiterating some things about the thyroid disorder as well. So if this is a bit of a repeat, I do apologize there, but there's nothing wrong with hearing something multiple times because sometimes it takes that. We're also going to talk about parathyroid and calcium as well as diabetes at the end with a lot less focus on pharmacology, and we'll talk about that when we get there. Next slide. I want to point out something that the endocrinology and endocrine systems function on, which is the concept of homeostasis. The body wants to maintain something that is normal and what it is used to. And as a downside, that regulation many times gets impaired, like with many other systems, as we age. The biggest problem is when the endocrine system tends to lose some of its function, there are compensatory changes that are made to kind of make up for this lack of function. As an example, we might need to see some changes in general metabolism to make up and maintain that homeostasis that is being deferred off of. Now, in some instances too, we're not even able to make all those compensatory changes. And so it will then manifest as something where the body is trying to make up for these losses, but can't effectively do it. Next slide. One of the issues revolved around trying to identify that there's a problem happening with the endocrine disorders is that many of their symptoms are very nonspecific. They might be muted or not normal general signs and symptoms in the older adult. I'm not going to lie to you, in the thyroid hormone realm, low thyroid hormone would manifest as fatigue. And if you played that game, pretty much everyone would have a thyroid dysfunction. Let alone in the older adults, are you seeing things such as side effects to medications that you might think could in fact be a side effect from a med? It could actually be a sign or symptom of an endocrine disorder. Likewise, people can have these endocrine disorders and still not feel anything at all. You very, very, very much have to rely on laboratory assessment as well, but that also can be convoluted with some other coexisting illnesses and other medications. Again, I'm going back to the thyroid disorder, but patients who take biotin can actually augment their labs that are necessary for diagnosing thyroid disease, which the older we get, a lot of time people take these vitamins. Plus, a lot of the lab tests that we use really have what we call normal ranges for healthy adults, not necessarily healthy older adults. So we still have to recognize that something might look normal that might be atypical for somebody who is older. Next slide. First system we will talk about, and I'm hoping to be a little bit briefer, is the thyroid system. And in particular, we're mostly going to talk about the relationship of the TSH listed there and then the T3 and T4, which are the actual thyroid hormones. Next slide. The thyroid hormone, in a nutshell, that its job is to affect metabolism. Now, we all hear metabolism as metabolic rate, and that's more than just that. Metabolism as a whole is just biochemical pathways. Now, if the biochemical pathway is related to affecting how much calories you use, then that is really affecting the metabolic rate. But just a metabolism as a whole is just chemical reactions that occur. Now, if you have a high metabolic rate, you would expect weight loss. And if you had a low metabolic rate, you expect weight gain. Those get impacted by thyroid levels. Again, just to list, without listing off everything, you know, the thyroid hormone affects practically every organ in the body. You just have to ask yourself, what is that organ doing? So in the case of the heart, if the thyroid hormone is present, it will raise the metabolism within the heart, which will then raise the heart rate. An exact opposite would occur in low thyroid hormone levels. Next slide. Of note, as we age, the thyroid hormone tends to decrease slightly. It doesn't actually make major decreases, but what does change is this thyroid regulatory hormone, which is known as thyroid stimulating hormone, or TSH. That concentration shifts towards a higher level. Now, to us in the healthcare world, when we just see a elevated TSH level, we can instantly assume that their thyroid hormone level must be low. In this case, you could very much still have an elevated TSH level, but still have normal thyroid hormones just by the act of aging alone. And it creates this kind of what we call biochemical hypothyroidism without actually being true hypothyroidism. Now, it is recommended to still test for TSH, especially in older adults where you are starting to see a decline in clinical, cognitive, or functional status. Because if by some chance your thyroid hormone level is in fact low, and your TSH level is in fact elevated, you could see things such as decline in overall health, which it's fair and good to rule that out. If it just so happens to be their TSH and their thyroid hormones are off, then there's the solution, but it's not always true. And likewise, in patients who get admitted to a nursing home, it's good to probably have a just general baseline TSH. Next slide. As it implies, hypothyroidism is low thyroid hormone. And so the typical symptoms is what goes around with low metabolism. So I expect weight gain, slow heart rate. If your metabolic rate is low, your body temperature might be low. If you're the bowels, in order for them to move, they need the metabolic rate to be active in the bowels. So if your metabolic rate is low in the bowels, you will have constipation, just to name a few. Again, decreased energy, focus, and depression, you know, depression in itself could be just from depression, but it could very much be also because of thyroid hormone. There's an example of how it can be convoluted to disease states and two signs and symptoms, or similar signs and symptoms with two disease states. You must recognize that there are other confounding health conditions, as I just said, and you very much need to have confirmatory laboratory testing in order to definitively know if somebody is truly having hypothyroidism. Next slide. There's a little mini group called subclinical hypothyroidism where the TSH, that regulating hormone, is slightly elevated, but your thyroid hormones are still normal. And that's the example of what I tried to point out in just normal aging processes. Generally, it can occur, and it does occur more in the women. If you happen to find somebody who is just slightly off in their TSH level, you should not just chase trying to fix that TSH level, especially in the elderly. It's not the end of the world. You have a chance to cause more harm if you try to fix a thyroid hormone level that's not truly off. So it is still recommended to screen and make sure that these thyroid hormones don't progress into true hypothyroidism every 6 months to possibly a year. Next slide. I'm using this as an example to kind of show basic ideas. This is not the entire everything around thyroid hormone replacement, but the most common option that we use is Synthroid, which is also levothyroxine, which is the actual thyroid hormone. We just put it in a pill and people take it. From the average, if you follow the normal dosing patterns, you're supposed to just take somebody's weight, multiply it by 1.6, and that's the average amount of Synthroid that a patient needs. There is such a thing as doing too much. If we, by some chance, were to give too much thyroid hormone level, we can elicit some major complications, mostly around the heart. And because somebody's older, they're much smaller, the demands that they might need is much lower. And so as a rule of thumb, you tend to start only 25 to 50 micrograms as your starting dose if you're older. Again, you could be a 100-kilogram patient. That would imply you need 160 micrograms per day, but you err on the side of caution in elderly just because of the chance that this is not true hypothyroidism, or at least needing to meet the total assumed demands because you are an older individual, not an average adult. And if you have cardiac disease, we start even lower because arrhythmias can occur with too much thyroid hormone. And with you being older, you might be more sensitive. We start lower than we think we need. Next slide. Now that shifts straight into the exact opposite of hypothyroidism, which is hyperthyroidism. And no surprise, you get the exact opposite of what is seen in hypothyroidism. So as individuals have high thyroid hormone, they might have some weight loss. They might have some faster heart rates. Their body temperature is warmer. They're more intolerant. Diarrhea is another possible sign of hyperthyroidism. But again, diarrhea is also a side effect of meds and complications of others. It's very easy to see that we might mix up seeing hyperthyroidism when in reality it's just a side effect of a medication. Next slide. Now, a lot of times the older individuals have a specific type of thyroid hyperthyroidism called Graves' disease, where the body itself is kind of attacking the hormone of the thyroid and tricking the thyroid gland to make extra hormone. As a result, atrial fibrillation is threefold higher. And so that's the reason we very much like to not have too much thyroid hormone on board, whether we give it artificially or the body is making it. As a result, too, bone metabolism. Again, if I have too much thyroid hormone, then the bone's metabolism is going to go up, which increases the bone's metabolic rate of breakdown. And a consequence of hyperthyroidism is, in fact, osteoporosis. There is an association of having cognitive impairment and dementia in the elderly with high thyroid hormone, but we really don't know if treating it will then prevent that cognitive decline. You know, if the decline has started, is it too late? We don't know. So that's where you still might want to consider treating the hyperthyroidism, but just know that it's not so much from the cognitive impairment improvement. Next slide. Back to this whole, it's not exactly hyperthyroidism, but it's pretty close. Patients might have very low amount, but still some of them would have this situation where their regulating hormone level is in fact low, which we would think that means they're hyperthyroid, but their thyroid hormone levels are in fact normal. This is one of those few cases where actually maybe you are allowed to consider thinking about it, because even if you do have a slightly low regulating hormone level, you might actually still have atrial fibrillation, or the risk of atrial fibrillation is higher. Likewise, it's only slightly elevated thyroid hormone level, and yet the bone mineral density does still go down. So this is an exception to the rule where with hypothyroidism, if it's slightly off, you can kind of let it ride. But if somebody has slightly high thyroid levels, we still err on the side of caution and consider treating it. Next slide. The only issue is most common treatment is radioactive iodine. Is zapping the thyroid with some specific iodine that will then, for lack of a better term, just destroy the whole thing. If the thyroid does in fact get radioactive iodine, they effectively become hypothyroid, and you have to treat them just like a patient with hypothyroidism. We can sometimes use meds for the treatment, but when in doubt, the radioactive iodine is the preferred treatment option. More than likely, as the last bullet point states, though, they're going to develop hypothyroidism, and you more than likely need to treat them with Synthroid or thyroid hormone replacement after radioactive iodine. Next slide. This is something I wanted to point out, because when you talk to patients when they have something wrong with their thyroid, it might just be a nodule, which again is just a little mass, a little bubble, blip, you name it, something is there. It's very easy to believe that that nodule is something significant. No offense, the incidence of developing these nodules within your thyroid it goes up naturally with age. And a nodule is present in about 90% of all women over the age of 60 and 60% of men over the age of 80. So a lot of times when patients have concerns, they think that they're, or I shouldn't say it that way. When you look at it that way, if you have 10 women over the age of 70, 9 of them have some sort of nodule on their thyroid. And most of the time, we can't even feel them. That's what that's why it's of less concern. And what's exciting too is most of them are benign. They very rarely do anything. But it's easy to say that if I'm seeing a nodule or feeling a nodule, I need to be alarmed. You can be alarmed, but recognize that it's most likely not as severe as you think. Next slide. Most nodules, in fact, are very rarely cancerous. But in order to figure out if they are truly what we call non-functioning or what we call cold, essentially like a nodule that just is existing, there does need to be a fine needle aspiration to exclude this. But as a positive, more than likely, it will have no cancer risk. If somebody does have a nodule that is greater than 1 centimeter, it usually needs evaluation, but recognize that most nodules are of not concern. Next slide. As the name implies, para is right next to the thyroid gland. The parathyroid glands actually exist within the thyroid gland, but they are separate entities. The parathyroid gland, as we're going to find out, regulates calcium homeostasis. So as calcium levels adjust, the parathyroid hormone level will also adjust. The parathyroid hormone also will impact some of the reabsorption of the calcium in the kidneys, as well as helping ultimately lead to more calcium and calcium absorption in the gut. At the end of the day, parathyroid hormone is trying to raise our calcium levels because homeostasis, if our calcium goes down, to reach homeostasis, we must raise our calcium again. Therefore, parathyroid glands secrete parathyroid hormone. Next slide. As we get older, and what's interesting is like older starts at the age of 30 when it comes to the parathyroid gland, the parathyroid hormone just naturally goes up. Interestingly enough, though, the real reason the parathyroid hormone gland or our parathyroid hormone should be going up is because we're naturally seeing a decline in our calcium levels. So the parathyroid hormone is secreted more to then raise our calcium and kind of keep our calcium looking normal. When we do a blood draw, we see a normal calcium, but that could be because we're consuming too little calcium. And so then as our calcium levels go down, the parathyroid hormone gets secreted at a higher level to maintain this homeostasis. This balance of having extra parathyroid hormone tends to lead to a favoring towards more bone breakdown if your PTH levels are higher. And as a result, it leads to decreased bone mass and one of the risk factors for osteoporosis, having too much parathyroid hormone. Next slide. One element to this we have to recognize is with vitamin D. Vitamin D activation is part of what parathyroid hormone helps to ensure, albeit this does occur at the kidney. The vitamin D level is allowed to be thought about with PTH as well. If your vitamin D level is low, then you might be lacking some absorption of calcium. So if your calcium is then low because you're not making enough vitamin D or consuming enough vitamin D, the calcium's low, body will secrete PTH to then break down bone to raise our calcium. So one thing you might need to address is ensuring that somebody is not low in their vitamin D. We measure vitamin D by looking at the activated level of 25 hydroxy vitamin D. I'm just going to refer to that as activated vitamin, or excuse me, just as activated vitamin D moving forward. If their vitamin D is less than 20, then it is known that they're considered having low vitamin D. And it's very common. I'm here in North Dakota. It is very dark throughout the winters. And so on average, this says 33% of women. I don't know the stats off the top of my head, but I feel like it's almost every patient in North Dakota could benefit from some sort of vitamin D. As it implies, natural sunlight is one of the major sources. But if you're not getting adequate sunlight, you can supplement it with vitamin D exogenously. The other reason we kind of play around with vitamin D is because it is known, and it's a bit mixed, and I say that because I feel like every study that comes out, there's one positive and then one negative and then one neutral study about trying to understand what does vitamin D do beyond just fixing calcium levels. There has been an increased association with muscle weakness and fall risk, tends to be found in patients who have low vitamin D. Now, again, is that just from the low vitamin D? Is it from the bones are already starting to get lower in mass? I'm not sure. But the association is if you have consistent low vitamin D, your fall risk is elevated. And likewise, if you have low vitamin D, as I implied, your calcium's low, body secretes parathyroid hormone. And then if you secrete too much parathyroid hormone, you get bone breakdown. So you could actually fix potentially this endocrine disorder all by just ensuring that your vitamin D is repleted. Next slide. There really is no recommendation for like when to screen for vitamin D. I swear, patients up here, we should probably just do it to check. But other individuals who are older, the individuals that are a higher risk of vitamin D deficiency are listed below. And it's fair to say that if somebody has osteoporosis, if somebody has fall risks or multiple fractures, those are indications that you should always check and make sure that their vitamin D is in fact not deficient. Likewise, malnourished and losing weight, and it has nothing to do with, I mean, they're frail, those individuals, but they also might be consuming less vitamin D naturally just by being malnourished. So those might be individuals that'd be great to screen for. There is one other type of vitamin D called 125, whereas what we've been talking about is just 25 hydroxyvitamin D. Those levels are not very useful unless it is in patients with kidney disease. So if somebody tries to suggest getting 125 hydroxyvitamin D, if you don't have kidney disease, it's less useful. Next slide. The real debate is who you talk to on how much vitamin D we need to consume. And so there's a bit of a debate between the National Institute of Health as well as the American Geriatrics Society here of trying to determine what is in fact too little. You know, I'll give an example. If somebody's vitamin D is less than 20 and you brought it up to 25, is that good enough? To the NIH, it would be because we believe that greater than 20 helps with bone health. Now, the American Geriatrics Society believes that less than 30 is associated with some of this balance issues, muscle weakness. And so their argument, as long as it's above 30, is what you should be shooting for. It's still situational on how I approach it and how I believe you should. If somebody came back to me and their vitamin D was at 25, but they still have osteoporosis and their osteoporosis is getting worse, like, you know, that might be a situation where that patient does in fact need higher than 20, or excuse me, higher than 30. But the American Geriatric Society weights heavily towards ensuring somebody is above 30. Next slide. And I'm throwing this on here for your guys' reference to kind of show where there's a bit of a debate in terms of how much vitamin D individuals who are older should be consuming. And when in doubt, to make it easier, as long as a patient is getting at least 1,000, you're meeting everybody's criteria. There is such a thing as too much vitamin D, and so we do want to be careful about that. In particular, if we end up having too much calcium absorption, so you have to look at the calcium along with this. But in general, as long as somebody's consuming 1,000 units, you should be in an okay place. You must get vitamin D levels afterwards, though. If they're still low, you really base it off of their vitamin D level. So if somebody's getting 1,000 per day, their vitamin D is still below where you want it to, it's fair for that individual to get a little bit more vitamin D over the usual general recommendation. Next slide. Everything we were talking about before was assuming low calcium. If a patient comes to you who has just had high calcium for no reason whatsoever, you've ruled out everything, they're not taking extra vitamin D, they're not taking extra calcium for fun, there's a possibility it is either primary hyperparathyroidism or malignancy. Those are the two most common reasons for just general baseline elevated calcium levels. It is much more prevalent in women than it is men. And one of the downsides is it's usually asymptomatic in the average person. It's not until you get a blood test and like, oh, hey, your calcium is elevated for no reason. One major difference, though, is the older adults tend to see some of the more neurologic problems that are associated with the high calcium levels. So that might be one bit of difference to be seen in the older adults. The diagnosis must in fact be with a PTH level in presence of calcium elevations as well. Next slide. Truthfully though, the most common practice for treating of hyperparathyroidism is surgery. Finding either if there's one nodule, one of the 4 glands that are hyperactive and removing it, possibly removing everything. It's a matter of just making sure that the patient fits the criteria. And if a patient is in fact symptomatic from their hyperparathyroidism, that's a strong reason to just get rid of it. There are listed below other ways and times when you can consider surgery in individuals who have elevated hyperparathyroid. Next slide. One of the things that's interesting is if somebody does in fact have hyperparathyroidism, is it still because, I know it's primary, it implies the gland itself is broken. What if somebody is still vitamin D deficient along with having hyperparathyroidism? That individual would have high calcium, but you could still in fact have low vitamin D. And we still know that low vitamin D might impact frailty, falls, and everything. So you can still try to treat somebody with vitamin D who is low in their vitamin D. You just got to be very careful because you make the risk of them having higher calcium even higher. It's less so much of the we have to treat it, but watch cautiously. Other things we can do for treating hyperparathyroidism, the bisphosphonate class that's listed there is what we normally use for osteoporosis. And that's, again, to help ensure that the parathyroid gland does not cause the bones to get broken down. There's another medication we can use that's essentially a receptor that helps sensitize the parathyroid gland to calcium. Because then if the parathyroid gland actually can recognize the calcium is normal, then it might stop working. But most of the time, we need to resort to surgery for fixing hyperparathyroidism. Next slide. This shifts us out of the general endocrine disorders, and this is the focus on diabetes. In starts with diabetes, no matter what. It is very common. You know, I keep seeing the numbers change. The last CDC instance that I saw showed it was 30% of the population has diabetes, which is rather elevated. Of those who are greater than 65 years of old, they, again, mimicking this 27% have the diagnosis or even don't know they have diabetes. When you look at it, individuals of the Black or Hispanic race tend to have a higher incidence of diabetes comparatively. And the major negative is the Black American race tends to suffer from the complications of diabetes disproportionately. So diabetes does cause issues. It's more likely to cause these issues in the Black race. Next slide. Of the older adults, there is a higher rate of these blood vascular problems and other geriatric syndromes just by having diabetes. And there's a 10-year reduction in life expectancy and mortality rate. It's twice that of those without diabetes. So again, you look at somebody who is older with diabetes, they're 2 times more likely to die than somebody without diabetes of the same age. There's increased mobility problems as well as disabilities in their activities of daily living, which sometimes can actually come from the fact that their health overall is changing because of their diabetes. Next slide. As a reminder, there's a breakdown. Type 1 and type 2 diabetes. Type 1 is from the body itself attacking and destroying the pancreas, in particular destroying the part of the pancreas that makes insulin. If you are type 1, you have to use insulin. There is no ifs, ands, or buts. You have to use insulin with each meal. You have to use insulin once a day, even if you're not eating. And it is of note that we are getting a lot better at managing patients with diabetes, and we are seeing much more. I don't remember the stats off the top of my head. We are getting much more individuals who are older with type 1 diabetes, which is exciting, but it does bring its own subset of differences that you have to factor in. Type 2 diabetes is usually from the fact that our body does not listen to the insulin. That's what's called insulin resistance. Coupled with the fact that, your body is maybe only making, 30% of the amount of insulin that it needs in a day. So not only are not making enough insulin, your body's not listening to what's being made. That would be type 2 diabetes. Next slide. It is always important to try to prevent it if I can. And we have multiple studies. Like, this is known. It's not even a question mark of like literature, science, and all that stuff. Maybe it does, maybe it doesn't. If you can focus on your diet, exercise, weight loss, you can delay or possibly prevent diabetes happening. In particular, those who are already showing signs that they're looking like they might have diabetes, if you can start these lifestyle modifications, there is a high likelihood that you will prevent them from progressing into type 2 diabetes. Next slide. When somebody has diabetes, we do need to evaluate them. And it's very easy to think about the evaluations from a medical perspective, right? You must look for situations in terms of, do they have atherosclerotic plaque-related buildup somewhere in their blood vessels? Do they have other comorbid conditions such as eye disease, kidney disease? But I want to point out, there's many other assessments that you should consider in patients with diabetes, especially when they're older. For example, making sure that you understand their medications, and by some chance, is there a medicine that could be impacting their diabetes or impact their possible care? You need to assess their functional status, because diabetes is a condition that does require you to kind of be very active in understanding what's going on. And if you're not able to physically or mentally help address this, you really need to, we would look at your goals of care differently. We would want to screen for multiple geriatric conditions, such as polypharmacy, functional impairment, urinary incontinence, falls, pain, cognitive, depression, you name it. And screening impairment for anyone over the age of 65 should be done annually. Likewise, you need to screen for some psychosocial and social issues, making sure that you have family members on board, or is that a barrier? Cost is another barrier. Any issues for why you could not be adherent. It doesn't matter what medication I use in you, the best medicine is the one a patient will take. Next slide. The piece I want to get at when it comes to dealing with the older population is the goals of management differ to an extent. The whole reason I want somebody's diabetes controlled is because it is known that elevated blood sugars will damage other organs throughout the body. That does in fact take time. If you have diabetes for 1 month, sure, maybe you're damaging the organs a little bit, but it's not enough to make some clinical difference within the first month of the disease. So with that in mind, you have to factor in all these elements to try to understand what is the goal of care for somebody who is older. And the ADA, many guidelines will state that there is no one goal for everybody. This must be individualized, whether that be targets for blood sugars, whether that be for making sure that the risk of other diseases, as I said before, the atherosclerotic or microvascular diseases, is assessed. Truthfully, I don't want just high blood sugars to exist. I want those gone, but I hate lows more than I hate highs. And so one of the goals maybe is, if the hypoglycemia, low blood sugar risk is so high, maybe that's the goal. I don't care about fixing the highs anymore. I want to make sure you don't go low, and that is fine as a goal. Next slide. Elements to this goal is recognizing, as I pointed out, life expectancy. It's a bit morbid to think about, but I'm just going to tell you right now. If somebody gets diagnosed with diabetes and you look at them and the prognosis is 6 months, I'm not going to lie to you, there's not much that I can prevent from there. There's no point at trying to chase the prevention of the complications of diabetes if you are going to, if you or your patient, loved one, you name it, is going to die before you get these complications. Keep this in mind. As an example is listed there, you might need over 8 years of some benefit of some of tight blood control to actually benefit some of these conditions. So congratulations, no offense, if you do not have 8 years of life expectancy listed on average, there might be no benefit at trying to get perfect blood sugars. Some other elements such as blood pressure and cholesterol take less time, but I repeat, it still takes 2 or 3 years to get the benefit of what we're doing for the whole reason that we give you these medicines or make some of these changes. So it's not always trying to get the good numbers. Sometimes the goal is recognizing that we can't actually get these good numbers in a timely manner, so it's not worth trying to chase them. Next slide. As a general principle, you do factor the health and functional status of the individual. And I look at an older adult, and no offense, like if you've got an older adult who's 70 years old, and I tell my students this, my residents, everything, if you got a patient who's 70 years old, but you look at them and they're physically and based on their health, frankly, they look like they're 40 years old, then maybe it is okay to actually attempt to manage their diabetes the exact same way. Now, you've got somebody who's 70 years old who, again, they're 70 years old and they look like they're 70, or maybe they look like they're 75. Maybe the goals are less strict. Maybe there's a chance we can start to lax out on some of these because it's not worth trying to chase these perfect numbers as you start to get older and some of these complications are less preventable. Lastly, for some older adults, you really don't need to do anything. As it listed there, and I firmly agree with this, you can cause more harm trying to fix somebody's diabetes. I'll give an example. If somebody has a low blood sugar, common symptoms are shaky, sweaty, dizzy, lightheaded. All things, if you're an older individual, have a high likelihood of leading to a fall. So congratulations, you fixed their blood sugar. Congratulations, you caused them to have a fracture potentially. Was it worth it trying to fix their blood sugars? These are all questions you have to ask yourself. And for one patient that you have that is 75 years old, maybe you do make those changes. And for one patient at 75, it's not worth it. And that's totally fine. Next slide. No matter what, you should always ask some general questions. So and it's known that smoking cessation, having appropriate eye and foot care is still something to factor in because if I could prevent diabetic foot infections, that's one thing that would be useful to make sure patients are prevented from. Always ensuring that they're adherent to their meds. Always ensuring that a patient is up to date with what it takes to understand their diabetes. If needed, weight loss and increasing physical activity, appropriate nutrition. But again, these are all elements that you should have conversations with to ensure. Studies show that these are all great things to incorporate, but the individual goals depend on the patient. Next slide. It is still important to recommend vaccinations, and that's just known, again, just from overall population health. Foot examinations are still important. It's hard to think, but while the goals of care might shift, there's still some preventable negatives that we can get at much easily, such as amputations, if we could just do something as simple as a foot examination. And it is still important to consider screening for kidney disease. And I'm pointing this out just because if you'd asked me this 2 years ago, this bullet point would have been less profound. We are, in fact, getting more information with some of the meds we use in diabetes and their impact on the kidney in a positive way. So it's still fair to consider in certain individuals to screen for kidney disease. For sure, you should do it at diagnosis. And annually, I am leaning towards now suggesting it much more frequently because if by some chance your kidneys are going to go out before, correction, how do I word this? If your kidneys are deteriorating, and I could prevent that deterioration in a positive way that gives you a better quality of life, then it might be worth it to consider using some of these meds. And I repeat, I would not have made this recommendation maybe two or 3 years ago, but that's how advanced we are getting with some of these meds. Next slide. I do want to point out that education is important, whether that be for the patient, the family members. I'm not expecting somebody to be an expert in diabetes management, but you'd be surprised. There might be some patients who are actually doing things that they thought were beneficial for their diabetes that turns out is actually harmful and they just had no clue. So it is still fair to consider having some sort of referral to a diabetes educator, specific management programs. The way I operate is if a patient has diabetes that needs extra help outside of the normal primary care goals, I then can get consulted. I want to point out that Medicare does in fact pay for diabetes education. So don't think that it is a barrier of cost or a barrier of access. It's more of a barrier of access if you don't have enough diabetes educators, but Medicare does in fact pay for education. And It is also important that if a patient is cognitively impaired, you might need to give some of this education to those significant others, those loved ones. Next slide. And as I pointed out, these are different elements of which can in fact be taught to the patient and caregivers regarding some of their diabetes management. Next slide. I want to point out that, sorry, my slides, my computer shut down. Give me a second. Okay, it's much less likely. I don't need somebody to have perfect blood sugars, is what I'm trying to point out. We question perfect as around less than 6.5, but in reality, that is not entirely necessary. And I want to point out that sometimes the targets can be individualized, anywhere from 7 to 9. It's up to you and the patient to determine what's worth it. Or you might not even rely on the A1C. You can choose to use blood sugars. We can use these fancy new machines called continuous glucose monitors. Maybe those are good enough. You know, we don't need the A1C as a complete target. When in doubt, if I try to fix your blood sugars and your A1C, I might hurt you. And if it looks like I'm going to hurt you more than the consequences of diabetes, then it's not worth it. Next slide. Now, I did want to point out that low blood sugars are not good. I think it's known. But in those who are frail, there is a higher likelihood of increased mortality in individuals who have more low blood sugars. So if you do need to assess and make sure that if somebody has a history of low blood sugars, or do I believe that they're going to be able to fix their own low blood sugar, then I might want to say that the medications that I use, I would avoid low blood sugars or medications that can cause lows. Next slide. This is a kind of summary slide that I'm going to leave for you guys that at the end of the day tries to point out, you ask yourself the question, is your life expectancy, as an example? So the third one down is life expectancy. If you have a longer life expectancy, then that would imply I would need more strict blood sugar control. Whereas if the life expectancy is short, I don't need as strict of blood sugar control. These are all elements that you have to point out. And maybe somebody has a long life expectancy, but a high cardiovascular disease, complications. You can use all of this to try to come up with an individualized goal. These are all the elements that you should factor in. Next slide. And looking at other elements or other stages of the continuum of care, I manage a decent amount of patients at assisted living. You need to recognize that assisted living is still kind of the patient manages themselves, but then you also might sometimes have support from the facility. And so it's kind of like a hospital, but not. So you might have different approaches in how you can do this because the patient might get extra help in their care. So it might make it so then you could be more hands-on because somebody else is doing it. That doesn't mean you have to. But a lot of times in patients who are still independent and at assisted living, you have some resources that make it a little bit easier to manage their care sometimes. Next slide. In the hospital, I do want to point out that we have found out that low blood sugars actually increase mortality. So we don't completely care about having tight, perfect control in the hospital. Most of the time when somebody gets admitted to a hospital, you're going to see them just on insulin only. And they might not have been a patient who was using insulin on the outpatient setting. When you're in the hospital, we just treat you with insulin. It's up to you to determine how to do it. What's interesting is in the hospital, sometimes the hospital staff sometimes forgets that if you're older and the expectancy is a lot lower, it's still up to you to try to say, like, look, we don't need the numbers perfect. But in the hospital, expect somebody to be on insulin therapy only, which is risky, but as long as it's managed appropriately, we can be okay. Next slide. At a skilled nursing facility, the issue is low blood sugars happen all the time, whether that be from food intake being low, the patient's health getting worse. It is tough to say. Somebody who's just because they're a skilled nursing facility and it feels like a hospital, err on the side of the caution more times than not. If your patient is unhealthy enough that they need to be at a skilled nursing facility, then more than likely tight control is not required. Keep that in mind. Next slide. The one that nobody wants to talk about is if somebody is palliative in hospice, and truth be told, make it the patient's goal. Like if the patient wants to not check their sugars anymore, that's fine with me. Recognize that we're trying to prevent suffering. The issue is low blood sugars can be suffering, but so can highs. You have to keep that in mind. If somebody has a blood sugar of like over 500 for an extended period of time, that can cause suffering too. So you do have to balance it a bit. But more than likely, you get to be less intense in their care. And so that's fine. If somebody is dying, you don't need to focus on diabetes management. And I wanted to put this quote that came from the guideline. Overall comfort, prevention of distressing symptoms, and preservation of quality of life and dignity are the primary goal of diabetes in patients, primary goals of diabetes at the end of life. Do not forget that. And I want to stress quality of life and dignity. Next slide. So in summary, after blazing through this, I think I've got a minute left. The thyroid hormone, sometimes it's tough to tell the difference between other health problems that might occur in the elderly, and that is something to be an advocate for, but recognize that thyroid is not always the answer. Calcium homeostasis, the older we get, leans towards low calcium, therefore we must raise it internally, usually leading to bone breakdown, increasing the likelihood of osteoporosis. Vitamin D deficiency is common and can contribute to osteoporosis other than just from other elements. And there's been associations of muscle weakness and falls. So it is still valuable to try to improve somebody's vitamin D levels. Diabetes is important. I think that is known, but we must address it and recognize that in the older population, some of these goals of care are very different. We can individualize it. It's not the same in the general average older adult. Sometimes self-management is just as important of diabetes of care. And frankly, it doesn't matter how old you are. Like you can benefit from education and you, the patient, empowering your diabetes care. I do want to say that the older we get tends to be that we don't have to be as strict on the control. We can focus on avoiding low blood sugars and short-term complications of hyperglycemia. That's fine. You might find an older adult who was trained their whole life. I have to have my blood sugar under this number because that's what it has been for my entire life. You are allowed to reevaluate what is the goal of care. It is less strict most of the time.